Hi, everybody. Good afternoon. Welcome to the 11th episode of the Health System Fix podcast. My name is Gaurav Mishra. I'm a child and adolescent and adult psychiatrist and a health systems expert. I'm very excited to have my friend Amanda Berry on. Amanda Berry is a public health social worker. She has a background in health policy, politics, research, and health services. Currently, she is the director of managed care advocacy at Health Center Partners of Southern California, which is a large consortium of community health centers in San Diego, Riverside, and Imperial Counties. Recently, because she just got promoted, so we'll congratulate her, but recently, prior to her promotion, she was the government affairs manager at Health Center Partners and helped strengthen their civic engagement, and she played a key role in successful passage of Proposition 35, which secured critical Medi-Cal funding. She's also served as a senior policy advisor to San Diego County Supervisor Terra Lawson-Remer. She's contributed to statewide behavioral health policy reform through her work with UC Davis. She also currently serves on the County of San Diego's Behavioral Health Advisory Board and is a co-president of San Diego Leadership Alliance. So welcome, Amanda. It's great to have you on.
Thanks for having me.
Firstly, congratulations on your recent promotion. That must be exciting.
Thank you. It's a very exciting time for healthcare.
I like to start talking to my guests about their early journey. If you can tell us a little bit about what was life like till you went to college, till you started to go on your professional path.
Yeah, I feel like I was very lucky. I grew up in Northern California in San Ramon, which is, basically think East Bay suburbia, Northern California, kind of quintessential white picket fence life, playing sports and being involved in leadership and other activities. I had a very lucky childhood in that way. It was something that I was kind of a leadership nerd. If you think about what cliques there are in high school and stuff, I was definitely a little bit of a jock and I played soccer and softball, but leadership was really my claim to fame. I ran for office and was defeated, unfortunately, for senior class president because of a well-placed pun on my last name. I got to say it was like one of my first exposures to campaign politics. My opponent, a good friend of mine, claimed to go berries when you can go bananas, dressed up in a banana suit. So I give him full credit for beating me in the campaign game. But growing up, I had a lot of exposure to math and science through my grandparents, who were both scientists themselves. My grandfather's a plant scientist. My other grandfather was a machinist, and my grandma was a speech pathologist, so had lots of people exposure that way. When I was in high school, I started to get involved in politics. And I started a Junior Statesman of America club at my high school. And through that, I had an opportunity to go see Obama speak in 2008 when he accepted the nomination at the DNC. And, this is before smartphones were really a thing. I didn't really have much access. And I went to Denver, and last minute they said, okay, the credentials we thought we had for everybody to get on the floor, we don't have those anymore. So you're on your own. And my parents weren't very politically involved necessarily. I didn't have any real access. I think that was my first experience of it actually matters who you know and politics and power and all of that. And I was so dejected. I was like, I can't go see Obama speak. What am I going to do? And I was friends with somebody on a bus, that I met, and their parents knew people and got us credentials to get in. And I was like, oh, wow. I guess it really does matter who you know to get access to things. That's when I got really interested. I phone banked and canvassed and walked and did all that, which is why I applied to college as wanting to do political science and communications. I was like, I'm going to be a campaign manager. I'm going to do this. That changed, but that was me growing up.
So my son, who's 8 and just ran his first student council election, and we were preparing for weeks, and he was well prepared, but I was just telling him, okay, your effort is what I value, but he won. So he was super excited. And Obama, I'll tell you a funny thing. I was brand new in the US. I had just started sort of coming here for residency. He won. I was in Chicago the night he accepted the presidency. My friend said, like, why don't we just go? And we were obviously outside the main perimeter, but like there were giant TVs and there were probably 40,000 people on the streets of Chicago just walking. It's a pretty amazing experience. What was the shift that made you think about going into social work and then going into public health?
Yeah. So I went to UC Santa Barbara for my undergrad, and I went in as political science communications, and they told me I couldn't take math. They said, sorry, math classes are impacted. You have to be a science major to take math, science or engineering. And I said, fine, I'm a bio major now. And so I changed my major because I loved math and science. And I kind of realized that I was going to get the training. And I've always thought about education, like college, grad school, as training for future career, how to think, or at least in education. And so I changed my major to biology, and then I ran for student government in college and said, okay, I'm going to keep my political interests in my extracurriculars, and in my formal training, I will learn about science. And so I did biology and I did biopsychology because I was particularly interested in the brain and behavior. And so that was the initial shift. And then, what that looks like in terms of my career, I spent a while trying to figure it out till I landed in this career path. But after college, I was a medical assistant for a while, and I thought, okay, I'm going to go into medicine. And I worked for an addictionologist, early days of medication-assisted treatment, and probably did too many urine screens. And I was like, I don't think I want to be a nurse, and I don't really know if I want to go to med school. And I worked for a brain injury support center. So that was like a clubhouse model. And that was more direct service. And so I got to actually help people. And I've always been somebody that really loves the direct service component. But then how do you actually change systems? I'm a policy wonk. Like, I'll go deep in the weeds with you on stuff. And so then I was at UC Davis working for their newly launched Behavioral Health Center of Excellence. And that was a product of Darrell Steinberg, who was Senate Pro Tem. And the launch of the Steinberg Institute was all happening in this space that I was in. And it was trying to translate the research into the policy. I'm like, oh, this is really fascinating of what does it look like to get the world of the ivory tower of academia into what actually happens with clients on the ground, and what is that translation through policy to create the incentives to make it happen, whether it's financing or regulation. So it was kind of a process. But to your question of like, how did I get in public health social work? And like my formal training there was a lot of kind of collecting the jobs that I wanted. Talking to people that were doing cool things that got me excited. I was like, oh, I like what you do. Like, this is interesting. And then finding out what their background was. And then I found the program at San Diego State, and I was like, public health social work. Wow, it's this intersection on the macro side of public health with the direct practice of social work and social justice movements. There's something that calls to you. I don't know if you've ever seen that. Like, you're like, oh, this is where I'm supposed to be. This sounds like me.
I think you important that you highlighted that you see the work people around you are doing, and being in that setting also is so inspiring. Sounds like the experience at UC Davis was also quite formative in making that decision. Could you think of certain examples of projects you worked on there that made you think of this career trajectory a little bit more?
Yeah. So at Davis, there were a few folks that kind of helped me frame my relationship to behavioral health in general, I think. At UC Davis, they do coordinated specialty care through their EDAPT clinic. And I was working with the researchers on that. And what was happening was like they had this really great model, and counties across the state of California were trying to do coordinated specialty care. But as a clinician, like, how do you actually have a model, and how do you do it to fidelity when you don't have the resources of like a big research grant, or your caseload's too high? So we were doing a lot of technical assistance with the counties to say, okay, like, we've got this model. What kind of training do you need? And I think about that a lot. And that we don't have enough behavioral health workforce. And we're trying to expand it. So we're doing things like Lay Counselor Academy that we're doing with my current role. But what does the specialty training look like? And, what does it look like to have specialists trained to serve older adults or people with early psychosis? So I was exposed in that way. And then I also got a chance to work with a health economist at Davis. And that was really exciting because she's the health economist that has a really strong focus on health equity. And some of the training we did in the different special populations, like behavioral health for LGBTQ communities or behavioral health for API communities, and like what are some of the stigma components. And so that was a really cool time because it was, I think, right at the beginning of the term cultural humility. Have you heard that?
Oh yeah, that's probably one of my favorite terms heard in the last couple of years.
Yeah, it's one of my favorite. And so I was working at UC Davis, and I was part of like an employee staff book club led by the researchers who coined the term cultural humility. This was in, 2014, 2016, like during a really interesting political movement, divisive time in our country. And to have the academic exposure to something was, I think, you're right, very formative for how I kind of approach data and how we integrate what we know into what we do.
I think cultural humility is such an interesting term. And I think you're lucky to be in that space, to be with the people who came up with it. Because if you just look at healthcare and implementation, you heard about cultural competence for the whole time. I think I just heard the term at a conference, and that makes that makes so much more sense than cultural competence that we've been using for so long. And any amount of training, I don't think it gets you to competence. Hopefully you're getting to humility. So I think that is such a good reframing of how, in general, I think healthcare needs to move towards, versus us telling patients this is what you need, to let's engage and be humble about what's actually needed. So I think it's just a great overall term of the tone of healthcare where it needs to go.
I was talking to somebody yesterday at a conference for the county, and how do we work with community-based organizations that are already like tapped into the communities and build trust? Like we talk about a lot, trust of medical providers and clinicians, with the trust of the community, and then bridging those gaps. I think cultural humility is part of that equation.
Yeah, and I think a long time ago, image of competence, image of knowing everything, image of telling the population what they needed was trusted. That's what gave people trust. But I think that's not existed in the last 20 years, really. And so just reframing that for the just health system in general, every practitioner within the health system is so important for them to think differently about let's truly partner with the patient and the community. So most of my life, I would say all of my life, has been spent in just clinical medicine, really. Just like you did 2 knee urine tests, I did about 4 months at Rush University. I was a volunteer in research lab. Very nice people, but I was slicing mice brain, and I enjoyed the first few times I had to do it, but then I said, okay, I just want to see patients. That's all I want to do. So there are many examples where I think public health and clinical medicine need to be better partners with each other. And I want to ask you, in your experience, what have been some places where you felt they work really well together? I think they're both such important forces that when they align, their impact is much greater than when each of them is siloed. So if you can think of some ways you saw them work, in some settings, they work really well together, maybe other settings, not so much. And any thoughts on that? How do we get it to a place that they're really working to just enhance each other better? And that's a broad question.
Yeah, I think it's pretty broad, and I run into it often in the government affairs world. And I ran into it writing policy when I was a policy advisor, in that there isn't necessarily enough time in the day to have really well-informed policy from the clinicians, because the clinicians are overwhelmed. They're doing clinical care. They're trying to serve patients, right? And then I guess I kind of think of policy development in a public health approach, in that, the analogy for public health is you've got this stream and you keep helping people out of the river, and Then you go upstream and you look and say, okay, well, why are people falling in? How do we build a bridge so that people aren't falling into the river? And, policy is generally macro. It's the bigger picture thing. And so what happens is we end up writing policy with all the best intentions to say we want to solve an issue. And we're building a bridge, but we're really already downstream. And then the clinicians are trying to respond to that policy implementation, and it's very reactive because there wasn't the upstream involvement of the clinical input in its how it was shaped from the beginning. And so you end up like making bridges on top of bridges, and some of them are halfway over, and some of them are riddled with stones, and it's almost like it's creating more barriers sometimes instead of just like stopping and getting the clinical involvement and the community involvement. But the problem is that takes a long time and it's slow. I think there's also some education component to the clinical workforce that is doing the work on the day-to-day process of where are the levers of impact? Where do policies happen? Like, where are they drafted? How can you shape them? And I think it takes two, right? It takes the people writing the policy to take the time and engage folks and really get thoughtful feedback. But oftentimes you're asking for feedback and people are like, I don't know what you want me to, you haven't passed it yet. It's not impacting me yet. So I can't tell you what's going to happen. So one of the things that I think works really well is to find the folks that are in the clinical environments that have that orientation to the upstream approach. And if it's maybe the public health oriented clinicians or folks that just have some interest in policy making or process improvement, maybe it's equality people, and engage those folks because they're generally looking at how do you solve the problem big picture instead of just how do I implement what you told me I have to do on my checklist. And I was thinking really hard about this. Do I know of an example that worked really well? And I don't know that I have one. I have got a few examples of puzzle pieces that kind of fit, but something that actually works well. I don't know if I'm thinking when I was at Sharp for my internship, I was trying to work with the social workers and we were doing CIE implementation and community information exchange. And I had these big, bold goals. I was like, CIE is fantastic. We're going to address social determinants of health. We're going to do all this stuff. And then when it came to actual day-to-day, consenting patients into the program and what it looked like in terms of capacity and workload for the social workers on the floor, it was a whole different environment. So I'm like, we got to get policymakers to go walk a day in the shoes of a clinician of how many patients you have to see and how many consent forms and paperwork and regulatory requirements there are. But I couldn't come up with a good example. Came up with a lot of bad examples.
And I think it's the other way too, that clinicians need to also walk in the shoes of policymakers, because I can't remember the name of the department of California has a newer department which the goal of the department is to save money in healthcare. And one of those strategies was to assess post implementation if somebody has been wasteful and then kind of take some money back. And when I heard that, I thought, this is just going to make people less innovative in a practical, on the ground sense. If you look at a health center, which is, looking at their money flow every month, every year, for them, they're not going to test new things or want to try new things for a population because they're worried if it doesn't meet the criteria, this money may be clawed back. Or I think the implementation needs to be almost personalized within the county even. The implementation of a project in La Jolla and Chula Vista is not going to be the same and shouldn't be the same, actually. Mm-hmm. So the policy has to be broad enough to allow that. I do think the CCBHC model, even though they have a lot of criteria in there, and I think some of it depends on who's your program officer, right? There's a lot of things that have to fit in place, but at San Isidro, we built CCB. I think it turned out really well. And because we met the criteria and then we were allowed to really create it the way we thought was needed for the community. And I think that's the level of freedom you need in wherever things are getting implemented. But that's so hard to do, for sure.
It's a really big challenge.
Even the COVID pandemic, I think, I had patients who, I knew have 2 jobs, 3 jobs. And early in the pandemic, we got switched to tele. And then people were saying, oh, if you're sick, don't go in person. And I'm thinking, if I have 2 or 3 jobs to make ends meet, and that makes sure my kids have food, and if I'm sick and my options are going to work and make the money so I can feed my kids, or not go to work because I'm sick, what am I going to do? I mean, I think so. Just the system was not set up for anybody who is struggling already financially to be able to get through that really well.
I think that orientation to what do our policies and systems look like for working families that, you know, are really deciding between, do I go to work and get income, or do I go to a doctor's appointment? And so much of how we design our policies and our systems is you align incentives. And if the incentive is that you need to pay for breakfast, lunch, and dinner for your kids, and and take the trade-off, you're not going to go to your appointment, or needing to go to multiple appointments. Like we run into that with health centers because of the same day billing issue for behavioral health, that the policy incentive isn't aligned for health centers to do behavioral health and primary care in the same day. And if you're a working mother, father, you're taking time off of work to go to your appointment, and you should be able to be seen. And I know a lot of health centers do it anyway and take the loss, but it's not incentivized in that way to make it so that you can get everything that you need to get done when you took the afternoon off of work.
And I think health centers, even when they try to do it, even if it's a loss, I think despite the intentions being good, because the incentive is not aligned even for the health center, I think the messaging becomes not as clear as it should be. It almost becomes like in healthcare, the baseline is go above and beyond. That's kind of message that goes out to the front line also, which is not a sustainable message in any industry. So that's why I think people leave healthcare, because the incentive needs to be aligned at the organizational level also for the message to be very clear to everybody. Tell us about, your work at, Health Center Partners.
So Health Center Partners, we are a regional consortia, which is basically similar to like a primary care association. We represent 17 organizations in San Diego, Riverside, and Imperial Counties, mostly federally qualified health centers, Indian health centers, and Planned Parenthood of the Pacific Southwest. And because California is so big, we have multiple regional associations that work on behalf of health centers. So, all of our health centers that we represent serve about 800,000 patients every year, which is huge. I know you know community health centers really well and federally qualified health centers. And so my work as a government affairs manager is working on local, state, and federal policy. And now as a director of managed care advocacy, I'm working in the managed care space. Almost 90% of people on Medi-Cal in California are in managed care. They are assigned to a health plan who is responsible for their ability to get care and services. And California's done a great job of trying to expand what services are offered under Medi-Cal, things like CalAIM and community supports, enhanced care management, to say, hey, we need to provide things like medically tailored meals and care management, particularly for folks who are experiencing homelessness, folks who are repeatedly going to the emergency department for care. Clearly, we need to look upstream and say, okay, how do we get these individuals healthy and keep them healthy? And that's pretty much the responsibility of federally qualified health centers who serve primarily folks on Medi-Cal and the managed care plans that coordinate their care. And that means that there's a lot of advocacy needs in terms of working on behalf of the patients and the health centers to align those incentives to say what kind of regulations are impacting this ability to provide care, and how do we move into a more value-based care system. Our health centers, through our clinically integrated network IHP, they actually do value-based care. So they take risk, and it's unique in that it's owned by the FQs. Its incentives are aligned, and they're actually paid for performance. Like all of the incentives go back to the health centers, which is not necessarily true across the country. pretty much on the forefront, on the cutting edge of what it looks like to do value-based care, particularly for federally qualified health centers and the Medi-Cal population. So it's a really exciting time. There's a lot of changes happening right now in particular. Some of the biggest changes to Medicaid since it was passed 60 years ago. I love opportunities where there are growth, where it's exciting. There's stuff that I can learn along the way.
I'm sure that you probably have run across health centers or leaders who are much more short-term in their approach than they should be ideally. What's your pitch to them? Do you have a pitch to them that gets them on the board to supporting the policy?
It's a good question. I'm a social worker by training, right? Like it is a meet somebody where they're at. It is trying to understand, okay, what's on your mind right now? Like what are your hesitancies and where do those come from? Where do they stem from? And then trying to address them. I think sometimes it's really hard, in particular, like now, being innovative is scary because there's a lot of uncertainty. And I think that in the value-based care world, there are different like models, there's different steps into how you get into value-based care and the level of risk that you take on. And I think our leadership at IHP has done a fantastic job of working with the health centers and really being a support for health centers in this space. And I think that's a benefit of being part of an association and being part of a network, is that you actually can learn from folks who are further along in the process. Some of this peer encouragement of, oh yeah, we went through that and what we learned worked is this, this, and this. And I think that's important for any kind of change to systems, is like, who's the person delivering the message and where are they coming from? Did they have an experience where they took a risk in the past and weren't successful? And what happened and why, and how do you move in it, the current environment?
And it is great to have a forum where you can actually discuss some of those issues. Are there some concrete steps you can identify about how do you get yourself ready for a leadership role?
Good question. I'm fairly new to my role. I think it's determined by the people you have around you. There are some people that are going to be really big supporters and push you to grow and to move. And then there are folks who are going to be like, you're not ready. And ultimately, you're the person who knows. I think that's true in healthcare. It's true in careers, is that you need to advocate for yourself. At the end of the day, you know yourself best, you know your capability. And I think that oftentimes we take work out of context, that people are working, but they also have lives. And it's important that you have a life in addition to your work. The second that your work becomes your whole world, I think that kind of foreshadows future grief, because when you leave a job, it's like, leaving a partner or losing a family member or something, if it's become your entire world. I think so. My approach is generally just like a learning. It's a growth. You are often learning the job before you're in it. I do a lot of self-reflection. I have a practice that I do a life plan day every 6 months, block my calendar. Nobody gets to bother me. Go do not disturb. I usually spend time in the ocean on that day. But taking account of all of the different components of my life, and career is one of them. But it's within the context of the rest of the things happening in terms of my family, my finances, all the different things that are important to me. And for me, that's been important for kind of mapping out what kind of trajectory I want for like a sustainable growth. Like I'm pretty young. There's a long road ahead. And thinking about like what are the areas that I'm interested in that I need to grow in. Like, what do I want to learn more about? And for me, like managed care is an area where like I have a lot of expertise, but I have a lot that I can grow in. And I think having an open approach to learning, to like, and we talked about cultural humility, but like self-humility of like, where am I the expert and where am I not the expert? And where can I grow? And what would it look like to become that person? For young people, I get a lot of questions from people who are like applying to grad school and stuff. And I had the opportunity to kind of shadow and see a lot of leaders. I was an administrative assistant, so I was taking notes in a lot of meetings where I was the admin in the room. Like I wasn't necessarily speaking or contributing, which in reflection gave me an opportunity to be a really great listener and to see how people actually navigated the politics of a meeting or how they structured an agenda, how they received feedback and things like that. And so I think being an observer and a learner is a really important step in that process.
I remember I kind of got myself invited to a lot of meetings in my last job. It'll just send me the invite. I'll be there. Don't worry about it. I'm not going to say anything, but it does help you learn a new area well if you're there, if you're in the same decision making space that people are considering different factors while making a decision. And sometimes from the outside you think that's a wrong decision, but you don't even know all the things to consider before you're in that space. So that's, if anybody wants to learn a new area, that's, you don't have to have an opinion on day one, but just being around that, it helps.
Yeah, I thought about that from like um, the higher you get up, right? We're thinking of like a health executives. You're now invited to a room, and then you actually hold enough power in an organization that everybody turns to you. And so how do you create a workplace or a company or an organization where you can have humility, creating an opportunity where you can learn and listen, no matter which level you are in an organization? And I think that's hard to do.
Yeah. I did the CHCF healthcare leadership program. And one thing I learned from there and almost adopted immediately was in my role at San Isidro. So I had a lot of amazing people on my team, but also they were all reporting up to me. So this, despite me trying to be the nicest leader or whatever, it is still so much hierarchy. So one thing I adopted was telling them, in fact, which is what's taught to us, is tell them, I give you permission to give me feedback or call me out if you see I'm doing something that's not okay. And even saying, I want you to do this versus I give you permission to do this is received differently. Now, not
Mm.
everybody took that up, but few people did take it up and say, "Oh, you remember you told me told me to call you out when you were doing something that we don't think is okay." So I said, "Yeah, I meant it. So you can tell me what you're thinking." But as a leader, it's so much more important to create that space, have that humility, because then the people on your team have so much to contribute and give, but they're not going to do it if you don't create that environment. So that's so critical.
Yeah, that's impressive that you did that and that people took you up on it. That means that's a psychologically safe work environment, right? If you can give feedback.
Also, I think if you're in a meeting with your team, try to give your opinion last. I think that's the other thing that's critical, because the moment you give your opinion, a lot of people who may have differences may not feel safe enough to give their opinion. I'm going to be the last one to speak at the end of an interview when we're making the decision, or last one to speak in the meeting if possible, because let's hear what other people have to say. And I think that was incredibly helpful. By the way, your social work training definitely in convincing health center leaders, it obviously comes through. And also, I think motivational interviewing, we need all of those skills at work also, and not just with our patients. Somebody thinking about a career in public health, what would your advice be? How to go about it? Even what kind of experience should they gather as they go through that process?
That's a good question, and I get a lot of calls from students and young people thinking about it. Now I get a lot of questions about policy roles and things like that. But one of the things that like I shared that I did when I was trying to figure out maybe what grad school program I wanted to go to, or if I needed a career, some of the advice I got was don't go to grad school unless you know you need the training for what you want to do next. Got a folder on my desktop and I started collecting job descriptions and thinking about how do I want to spend my time. And we spend so many hours of our day in our jobs that just because you can do something doesn't necessarily mean that that's how you want to spend your time on a day-to-day basis. And I think that having self-awareness of how do you want to spend your time is important, because public health and policy are so broad and they're purposefully broad. Like it touches so many parts of our lives that thinking about what components of it do you like. Like for somebody getting into it, I'd say maybe if you're really interested in public health, the American Public Health Association puts on an annual conference. I'm part of the public health social work section. There are scholarships for young people to be able to attend. And I think that exposure of going to different sessions and just hearing from people in the field that are doing that kind of work and seeing kind of what makes you perk up, what makes you sit up straight and say, oh, I'm interested in that. What makes you kind of Google something after? It makes you want to learn more and pay attention to those things. And then public health is very broad and macro. And yet I think having some depth in some particular issue area is important for not getting overwhelmed. Yeah, I'll often ask students when I'm teaching and say, what's an issue area that you care about? And sometimes it's reproductive health, and, sometimes it's the foster care system or whatever it might be. And start to pay attention to the the policies and the political environment around that. And that just means like reading news, listening to podcasts, talking to people, because so much of the environment predicates what actually happens. So if somebody's interested in a career in public health, I'd say like, don't be afraid to reach out and talk to people who are already in it, because they'll give you insight into what it actually looks like. And then read and reflect. And maybe I learned that in grad school, like maybe I learned that through, my exposure to academia, but reflection doesn't have to be in terms of essays. It could be just having a conversation like we are now of what do you think about something? And that'll help kind of shape. I mean, that's how I got to my behavioral health interest, in addition to, some family experiences. But that reading, that reflection, that collection of experiences is going to shape the way. Just don't be afraid to ask questions. I think, to that humility tone, like ask questions, because there's a lot of people out there doing it. And generally, I think people like to talk about the work that they do.
What are the two most exciting or most challenging projects you're working on right now?
That's a really good question. And it's very challenging. I would say I get excited about a challenge. I'd say these challenges are not ones that necessarily excite me. The challenge itself is the limited resources we have for Medi-Cal. So we're looking at legislation that has been passed federally, HR 1, the One Big Beautiful Bill, and its impact to Medicaid, and what's going to happen at the state. And the governor's going to come out with his budget in January. We'll see what the legislature does and how we respond as a state, how we respond as health centers, as a community, to what are really big challenges and threats to the Medi-Cal budget, to the population served, to the rates that are paid, all of these things. And I think for me, it's a challenge. It feels like I'm often like providing bad news to folks about what's going on. And yet there is some innovation opportunities. I just did a panel on work requirements with the county and was working with some community partners and Kitty Bailey and Karen Connolly about work requirements and what do we need to do to make it the least bad case of how many people fall off of Medi-Cal. And that requires trusted messengers, that requires the county, that requires the state, that requires FQHCs, a lot of different parts of our community. And I think one of the exciting things is that it makes people talk to each other. We have so many silos in healthcare that at a time when the threats to the ability to provide healthcare seem so far-reaching, it requires us to create coalitions and collaborations that maybe previously didn't exist because we weren't faced with that kind of adversity.
I want to ask you, would you mind going a little bit deeper in your life plan exercise? Because I think that's super interesting. I'm myself in a transition, so I think I need one myself. But are you comfortable sharing how do you structure it and a little bit about that?
I'm happy to share. I'm due for a life plan day, so it's good timing. I read a book one time. It was a self-help book that I think created the initial framework, and I can't remember the name of it now, but I'm sure I could find it. It was a little bit more faith-based. I'm generally not a faith-oriented person for this kind of work, but I thought it was a good framework. And the idea is that you pick different accounts in your life that are important to you, and they may change. So you're not always going to have the same accounts. Like sometimes a social account was really important to me, and financial accounts, career, health is really important to me. Family is really important to me. And I do it about every 6 months. And so I sit down the whole day, and I've got a couple of notebooks now that I do it. And it's a way to kind of reflect, because I'm not a journaler. And this is for me, like this is my really big journaling exercise, because I don't journal on a regular basis. I would love to be a journaler. I'm just not. Yeah, right? Like you're like, I know the benefits of it. I think it'd be really wonderful. It's just not happening. So this is my 6-month journaling process.
Okay.
And I outline the current state of the account. I do a quote or like an excerpt or something from something I'm reading, or something that resonates with how I feel about that. I do like an envisioned future. So it's a little bit of what do I want this to look like? And then it's tangible goals. So, more of the SMART goal strategy. So the first part is a little bit of envisioning, a little bit of like truth setting, if in the health thing of like, how often are you actually working out? What is your diet looking like? And then what is it going to look like in your envisioned future when I'm optimally healthy? And then what are my goals for it? And one of the interesting things for me, and I put them kind of in order of like what's consuming my mind in a particular time. So there are points in my life where like career was number one. It was like, I'm really interested in growth in my career. And then I had some family members going through some health issues, and I was really worried about that. And so my most recent one, my family was number one of what was consuming my attention. So that's been interesting, kind of like as a reflection process over time of like, where are you focused? So that's the process. And then I do like an outdoor time where I like go boogie boarding or swimming in the ocean. I try to go to different places where I can get away, phone on, do not disturb. There's a botanical garden up in Encinitas I did my last one at.
Okay. When you reflect, when you're looking at the last 6 months, are you kind with yourself, or are you holding yourself accountable for maybe things that didn't happen like you had thought?
I'm pretty kind. Sometimes I'm not. I'm a pretty self-critical person, but generally I carry things over, and it's frequent enough, yet infrequent enough that even if I use it as just a reminder of like, remember you wanted to do that thing and you didn't do it? Do you still want to do it? Is it realistic? I think at one point I wrote I was going to journal all the time. No way. That is no longer on my goals.
Take some goals off the list. But that's great. The life plan thing I'm actually going to try it in the next few days. I'm trying to redesign my work life and actually try to bring some balance, and not just balance, like recognize what is valuable and what's not as valuable. Maybe it was valuable back some time ago and not anymore. But yeah, it's been a pleasure talking to you and learning about your journey. So thank you so much for joining us today.
Thank you so much for having me. I love the conversation.
Thanks so much.